Well, hi, everybody, and welcome back. I am super excited once again to have Dr. Mansoor Mohammed on the show today. And Dr. Mansoor is a real repeat offender on the show. I think this is the fourth podcast. You're the only person who's been on here 4 times, Dr. Mansoor. So welcome to the show again. It's fantastic to have you back.
It's an absolute pleasure. I'm not sure, does that mean I have to repeat myself to be understood? Or, it's...
No, you've got so much knowledge that we have to share with everybody. That's why.
It's an absolute honor.
So Dr. Mansoor, today we are going to be focusing everybody on genetics and hormones in particular. And we're going to be focusing in a bit on the ladies, although this is very relevant for the men out there too. So don't turn off if you're a guy and just go, oh, well, this is for the ladies. This is also aimed at men. But Dr. Mansoor is a world leading functional genomics scientist. And we're going to be talking today about the hormone cascade and understanding our genetic pathways that we take with our hormones and why we need to understand this and how important it is for us. So, Dr. Mansoor, where shall we start with this journey of going through the hormones?
Well, I think the first thing we want our listeners to understand, and it's not lost on any young woman post-menarche, and so let's just define just 2 quick terms: menarche, the time in which a young woman begins her monthly cycle and she enters into young womanhood, all the way through menopause, premenopause, perimenopause, and then postmenopausally. That in all of these wonderful stages of a young woman's life, that this, what we call sex hormones, the steroidal hormones, the progesterones, the androgens, most notably testosterone, estrogens, and their respective metabolites, they influence the human body at a cellular and at a holistic level in the most fundamental of ways, okay? So that's the first thing, just to emphasize the importance of these sex hormones. The second is to clarify that with this importance, it's not just about external female characteristics of breast development or hip flare or thigh development or bum development or fat deposition. It's not just quote unquote about the obvious phenotypic or physiologic manifestations of these hormones. We have to understand that sex hormones impact every aspect of cellular behavior. These hormones, when produced, and by definition, hormones are messenger molecules that are produced in one part of the body, in this case, for example, the ovaries. They then enter into the bloodstream, circulate throughout the body, and then impact every cell and that cellular behavior. So the second more important point is our listeners have to understand that the way in which their bodies respond to these hormones define and contribute to every aspect of cellular function, every aspect of cellular function. Now, if we can appreciate that, the third thing we've got to appreciate in a young woman's body, okay, is that there's a circadian rhythm or a circadian, generally speaking, that there's a circadian nature to these hormones. In other words, it strikes me, and I attended a remarkable conference a bit over a year ago. It was with the Red Bull team of super athletes and their clinicians. And one of the clinicians, she is from the UK. She specializes in treating female athletes. That's her sphere, is dealing with female athletes. And in her presentation, we were all presenting at this conference, she said something that was alarming, heart-wrenching, but almost not surprising all at once. And that was, she said, she ran a survey on these female athletes. These are like top of the world female athletes, one of which, just to begin with, was one of the top, if not the top female soccer teams in the world. And she said, not a single one of these athletes, female athletes, were ever asked or made aware of the health of their monthly cycle.
Wow. Yep. And these are the top people, let alone all the other weekend warriors. And
indeed.
Yeah.
Right. And so she was beside herself as a scientist and a clinician, that for something as fundamentally impactful to the human body as those sex hormones. So for example, as she illustrated, depending on whether a woman is in her follicular phase or her luteal phase of her menstrual cycle, proclivities to injuries change.
Mm-hmm.
The flexibility of the ligaments in the body changes.
Wow.
The response to the body to different types and motifs of exercises changes. When is the female body? Again, we're speaking here at first in generalities of the average female going
Mm-hmm.
through a monthly cycle, not yet on the pill.
Yep.
We're going to talk about the pill as a
Yeah.
separate factor, but just as part of the normative circadian rhythm of the female body morphophysiologically, cellular, metabolically, at day 7 of the monthly cycle is completely different. And I'm speaking a little bit in extreme, as to the body when it's on day 15,
Wow.
as to the body when it's on day 20. And so you've got individuals demanding the very best from their body, optimal performance, and they have not yet even come to terms with the basal changes to the body between these stages.
Wow.
Right? And as she pointed out, so many injuries due to training in these athletes, and again we're speaking of athletes, but we can juxtapose that to, like you said, the average female trying to simply be the best version of herself, could be avoided if the young woman only knew what stage in her monthly cycle she was at, if the young woman only knew the oxidative stresses that are different during different times of the monthly cycle. So if I told you, Lisa, that at a point in your menstruating cycle, you innately, naturally have surplus oxidative stress, it really doesn't take a lot further to go to understand that in those times and days, the last thing you want to do is go, there you go. You don't want to put even more oxidative stress at that point in the body.
Wow.
Okay, and so on and so on and so forth. So in this third category, as you said, to establish the baseline that we're speaking of, we've got to understand the importance of hormones. We've got to understand that it's beyond just the outward superficial physiology of the body. And in this case, speaking of young women, we've got to understand that there is a circadian rhythm to these hormones. Now, once we understand these three bases, these 3 points, then we have to appreciate that a significant part of what controls that circadian rhythm, and then within that circadian rhythm, what controls the nuances of one young woman versus the other, relies upon their genetics.
Their genetics, yep.
Okay?
Yep.
And so once we understand the functionality of the circadian rhythm of the female cycle, literally, once we understand the gears that are going through those 28 approximate days, once we understand that rhythm, we understand the genes that control or significantly contribute to that rhythm, and understand that each individual potentially has variations in those genes that controls that rhythm. We begin to understand the nuances, we begin to understand the individuality of Paula versus Lisa versus Joanne versus Isabel. And so we begin to understand that once, as with every aspect of intelligent medicine, but few aspects of medicine are as boldly, innately different as the nuances and the individuality of a young woman's innate genetic control of the circadian rhythm. And we'll talk about this, we need to appreciate this. And the most abhorrent of complications that occur if you do not understand this individuality, one young woman to the next, and then you take that birth control pill. I am not, of course, I have no place to be anti-birth control pill. I'm a man, I'm not a young woman.
No.
So this is not about being anti-birth control pill, not at all. But it's to say, the simplest thing that we think that you can take 1,000 university young women, first year university student girls, young women, and somehow put them on the same birth control, literally the same birth control, and somehow expect that there's going to be the same effect, and somehow do away, minimalize, and even criticize a young woman who comes back and says, I find that I'm gaining weight. I find that my mood is not the same. And then because 5 other young women don't have those issues, the doctor says, no, that's not because of the pill. And they're dismissed, and they're not even appreciated as to the uniqueness of their body's response to something. Again, sometimes the pill is a saving grace
Yes. Yep.
for a young woman. But what we're speaking of here is in these three pillars, the fourth pillar is the individuality of the genetics of that young woman and all of the remarkable insights that a young woman can gauge from this. Before I go any further, and it's not a plug in the least, I hope I'm not uh, going against any
Yep.
regulation of your podcast,
No, no,
but
no.
there's a brilliant book called In the Flow.
In the
In
flow.
the
Yep. We'll
Flow.
put the link in the show notes to it.
I have no association with the author, but it's just she did an amazing job, and I'm trying to get the name as I'm speaking about
Yeah.
it. I'll remember the name. She did an amazing job without the genetics of showing how radically important a young woman understanding her circadian rhythm, how at different points of her month her body responds to different foods differently, her brain response, her emotive response. She's really
Wow.
done a beautiful job of highlighting the awesome, holistic, cellular changes that go through a young woman's body in these waves of
In this
circadian
month.
rhythms every 28 days. So
Wow.
this sets the stage, Lisa, and everything that we might want to talk about is predicated on this understanding and then the genetics that explains this.
That's a beautiful entry into this whole actual looking at the mechanics, if you like, of the genetic pathways that I do want to get into, because in other words, every single woman is individual. And this is the beauty of genetics in general, is that we can actually personalize once we understand our own genetic pathways. And, we do this, both in our profession, is to understand what our genes are doing and how they're expressing and how we can optimize the genetic pathways, if you like, in this case, with our hormonal pathways. And this has a real implication when it comes to things like the birth control pill, when it comes to, in my case, bioidentical hormone replacement therapy on the other end of the scale, going through the menopausal years, because these has implications. Whereas, if I take bioidentical hormone replacement therapy, and we've actually talked briefly on one of our podcasts about some of my hormonal, which I'm happy to share as well. I'm on a hormone replacement therapy, but I understand my genes and I understand where my problems may lie, and therefore I can keep an eye, both from a blood perspective, keep an eye on my hormone levels, but I understand my own cascade, and I can mitigate the chances, for example, of developing estrogen-based cancers, or like breast cancers or cervical cancers, whereas another person, if we put them on the same regime, may run into trouble.
Indeed.
Yeah.
And even without the, shall we say, more extreme outcomes or concerns, such as hormonally related cancers, but really just even the day-to-day well-being of the body, the risks of peripheral neuropathies, the risks of migraines or lack or resolving them, fatigue, weight gain, things that are the way your body responds to nutrients. Again, understanding where your body innately, your innate tendency is, as per explained by your genes, and we'll get into some profound examples of this, and then making sure that you act in accordance, because we have choices, and some of the choices we can make, and sometimes there are, I think there many times when we speak about human optimization, there's certain voices, and they have a point, that can say, look, but there are universal truisms. They're just things that we should all know are either healthy or unhealthy. And there are a few of these things. But what is remarkable here is, especially when it comes to female hormones, there are things that you might deem to be universally healthy, but actually can be either unhealthy or certainly not optimal for some young women
Yeah.
versus others.
Yeah.
Right. So we're really in the realm here of not just talking about universal truisms that are relevant with or
No.
without genetics. We're speaking of nuances that are so radically important. And might I then, Lisa, with that, if it's okay with you, I'd like to then set the stage of some of just set the stage for themes, things
Yes.
that your audience, your listeners, I'm gonna say a few things, and my hope and my goal is for many of the listeners out there, at least a few of these things should resonate.
Let's do
So,
it.
for example, how many young women out there find that their introduction and their experience to cyclical migraines kick in post puberty? In other words, here she is, she's living in the same home, same nutrition, healthy or whatever version of lifestyle. And the day comes where she enters into young womanhood, and right thereafter, not, not directly related to her flow as per what she could physically and visually manifest, but this concept of now dealing with migraines, a concept of dealing with a circadian rhythm to her mood and to her what she might find trouble for those first few years until she becomes an adult woman and she's got life experiences, but she's always found that she's having a hard time to express that she literally feels that her emotional resilience, that ability, that barometer to what tips her over that scale of resilience changes, and she's never, and no one has even asked her, by the way, do you see that it comes in patterns?
No.
Do you find that it happens and kicks in 3 to 5 days prior to your cycle? Do you find that that's when you see some of these changes in the body? Do you find that it kicks in a day before ovulation? Do you even know when ovulation is happening? None of these conversations even happen, so that these apparently unrelated just symptomologies of, well, there's some anxiety, or I get migraines, they're just brushed under the growing list of things that, well, you just take a pill for it, meaning a pharmaceutical treatment, or they're minimized and somehow they're accepted as just a routine part of, well, that's what it is to live.
Life. Yep.
Okay. Or how many young women out there have dealt with some of these symptoms of migraines or pain, fibromyalgic like pain, debilitating fatigue, and then something miraculous happens. When they become pregnant, for 9 months, most or all of their symptoms resolve.
Wow.
And how many young women have said to me, I can't tell you, Lisa. Again, I know that being in New Zealand, I'm not sure if you have to deal with the plague of Lyme disease. It's something that we have here more in
more
Northeastern
so
America.
overseas, but yeah.
But it's a bacterial tick-borne disease that ruins lives. And there are, interestingly, a preponderance of women who present with Lyme disease-like symptoms. Now, I worked in a clinic, and I was one of the first to describe this phenomena. And I had to say, not trivializing the horridness of the disease, I said to a patient, I said, those ticks don't like women more than men. Unless
so why are more
women
women presenting with these symptoms?
Presenting with these symptoms, unless women were more likely to go trekking and hiking and be exposed to, but here was the point. It was that there was a significant, in one of the clinics that we did the study in, there were a significant number of women who presented with classically what outwardly seemed as Lyme disease symptomologies of debilitating fatigue, almost concussion-like presentations, mental malaise, muscle aches and pains, as I mentioned, fibromyalgic-like presentations, and they were convinced that they had Lyme disease, and because it's such a polymorphic disease, many doctors were going ahead and treating them with massive antibiotics, even if they couldn't confirm the infection, because many doctors almost agreeably have had to say, because so many true Lyme patients are being under cared for, that there are some really good doctors wanting to do the right thing who were treating the symptom and the presentation per se. But amongst these individuals were a preponderance of women who were not testing positive for Lyme disease. So what was going on here? And what we did when we studied these young women was, we looked at a significant number who then went ahead and became pregnant during their proposed Lyme disease. And for the 9 months of pregnancy, all of their symptoms
No
resolved.
symptoms. Wow.
And I had to say to both the doctors and the patients, I said, your Borrelia, the Bundifori Borrelia
Yep.
bacteria, the bacteria that causes that, doesn't just take a hike during
It
pregnancy.
doesn't just go away.
It
So
doesn't just
it's
go
not
away.
that.
It's not that. So what else is at play here? Well, how many young women understand that during their menstruating months and years, the primary estrogen in their body is estradiol?
Yep.
During pregnancy, your primary estrogen is estriol.
Yep.
Estriol is not metabolized into the same byproducts as estradiol. Estradiol can be metabolized. Every young woman metabolizes estradiol into 3 byproducts.
Yep.
2-hydroxyestradiol, 4-hydroxyestradiol, 16-alpha
16
hydroxyestradiol. Now, every young woman produces all 3, but genetically, you are predisposed to producing more of one or the other, depending on your genetics. And if you happen to be the young woman who was predisposed to producing in the ratio more of the 4-hydroxy or even the 16-alpha hydroxy, and God forbid, more of the 4 and 16-hydroxy, as compared to the 2-hydroxy, the 4-hydroxy and to a degree the 16-alpha hydroxy metabolites are particularly inflammatory.
Yes.
They're literally inflammatory metabolites that the body has been designed to get rid of. But if you were that young woman that genetically was predisposed to producing more of these naughty metabolites as opposed to the much, much less inflammatory 2-hydroxyestradiol, then just innately, you're the young woman that every cycle of the body, when it comes around to the body metabolizing those estradiols, your primary estrogen, when you're menstruating, when that estradiol is metabolized for a period of 2, 3 to 5 days, depending on your particulars, your body literally, regardless of whether you were eating organic and living organic and breathing the best air in the world,
you're still
internally, you are producing an internal inflammagen, an internal thing that is causing both inflammation and oxidative stress.
Wow.
Now, during pregnancy, when you become estriol dominant,
you're not getting it.
You don't get these metabolites. And so when a young woman gets pregnant and she complains prior to pregnancy of these malaise and these symptomologies, and then come pregnancy and the only thing that has changed, and I've had young women cry in my office saying, Dr. Mansour, how did you know to ask me if I felt better during pregnancy? Because usually it's quite the opposite. People thinking, oh my gosh, I'm going to get morning sickness and I'm going to... These young women
were better off.
were better. And they would say, you know, Mansour, I wished I could stay, quote unquote, pregnant. Because those were the months where I actually had a relief from these
all
symptoms.
these horrible symptoms. And
so these, Lisa.
Sorry, Dr. Mansour. So these 4-hydroxy and the 16-alpha hydroxy to a lesser degree, because it's a rarer situation. This is in relation to the CYP19A1 gene, the aromatase gene. We're turning our testosterones into estrogens. Is there any? So when we go on if we put on the pill, which has got estrogen in it, and you're one of those women who have, and this goes for men too. My husband has a 4-hydroxy dominance, for example, which is a problem. Are we exasperating the problem when we take the pill without knowing it?
So just to clarify and add a layer of clarity, so estrogen and the estrogen molecule and the estrogen hormone is actually nothing other than aromatized testosterone. So a lot of young women don't appreciate that. You know, they self-identify with estrogens. You know, women tend to self-identify with estrogens, and men, quote unquote, tend to self-identify with testosterone. In fact, I had one of these absurd pop-ups on I was watching a food vlog, which is my guilty pleasure,
Yes.
especially during COVID. I like watching it, foods being prepared, and you've got these annoying YouTube ads that come up. And one of it was this buffed, male trainer, and he comes on the screen on the ad and he goes, well, testosterone is what makes a man a man. Well, not quite, but okay. So the point is, men need to understand that we too make estrogens,
Yes.
and women need to understand that the very estrogens that they may or may not self-identify with are really simply testosterone molecules that have been aromatized. Okay, so there is a gene, a specific gene, one gene, CYP19A1, as you have mentioned, and in fact, the parlance, the more common name for the CYP19A1 gene is aromatase.
Hmm.
And this gene, with its enzyme, chemically changes testosterone into estrogen,
Hmm.
i.e., estradiol or estrone, as the case might be. Okay, but then once you make your estrogen, your estradiol, let's just fix it at that, then there are other genes that make other enzymes that make the 2 or the 4 or the 16 byproducts.
Mm.
So specifically, there's a gene known as the CYP1B1, CYP1 Bravo 1. This is the gene that makes the self-named enzyme that takes some of your estrogen and turns it into the naughty
Bad.
4-hydroxy
Yep.
estrogen metabolite.
The
Now,
toxic.
the point here is different women and different men. And just to clarify for the male listeners out there, if you would think that estrogen was a female issue, and if you would think that 4-hydroxy estrogen was a female issue, think again,
My
because
husband has this.
we now understand that 4-hydroxy estrogen metabolites in men contributes to prostate enlargement, contributes to the inflammation of the prostate. For many years, in fact, for the last 2 to 3 decades, all of the research on benign prostate hyperplasia in men has focused on a testosterone
Yeah.
metabolite known as
SRD.
DHT,
Yeah. SRD
the
582
di
gene.
right? So DHT, dihydrotestosterone, is the product, it is the metabolite of testosterone produced by the steroid 5 alpha reductase 2, the SRD5A2
Mm.
gene with its enzyme, okay, produces that metabolite. And it is true that DHT, one molecule of DHT, has the potency to bind to androgen receptors as 6 molecules of testosterone.
Wow.
It's a much more
Super,
potent,
super testosterone.
super, right? So here's the thing. DHT is to testosterone as 4-hydroxyestrogen is to estrogen.
Oh, wow.
DHT is the testosterone metabolite that interacts with the androgen receptor much in the same way as the 4-hydroxy
Yep.
metabolite of estrogen. 4-hydroxy overproduction in men, we have now discovered, is a significant contributor to the etiology and the progression of prostate enlargement,
Wow.
benign prostate
Wow.
hyperplasia.
I thought it was just
Okay?
SRD, the
Nope,
DHT. So I need to,
nope,
yeah, okay. I need to
nope,
go and check that
nope.
with my husband.
Right? And in fact, now for the last couple of years, some of the actual pharmaceutical clinical trials to treat benign prostate hyperplasia has switched everything, all of our Propecia and finasteride, these
Yeah,
medications
yeah,
that we're
yeah.
currently, and just for the male listeners out there, it is unsurprising that the very medications that are often used for benign prostate hyperplasia were found or were then used for balding,
Yeah, but it makes
because the
sense.
same DHT that
Mm.
promotes male pattern balding is the same testosterone metabolite that overinflames the prostate. But
Wow.
now we understand that the males who have the 4-hydroxyestrogen preponderance genetically, why? Because they had a version of the CYP1B1 gene that made a version of the CYP1B1 enzyme that is more aggressive at converting estrogen into this metabolite.
Yeah.
So men, this discussion is equally important to you. But coming back to the females very quickly then, Lisa, you see, a young woman who does not know, who's going about her, her life and her teenage years and her 20s, not even knowing what is the degree, what is my innate tendency
My pathway.
within which I convert my progesterone to testosterone. What is my innate tendency to convert testosterone to DHT, that more virulent testosterone? What is my innate tendency to convert testosterone into estrogens? And by the way, once I make the estrogens, what is my innate tendency in converting it into the 2s and the 4s and the 16 metabolites? Because you see, if a young woman were to understand this right off the bat, Lisa, it defines why and how easily she develops lean muscle mass.
Yep.
It defines why she can eat the same foods, exercise the same as her mate, in fact, exercise more than her mate, and be fit and be beautiful and be strong, but never get that cut or that sort of striated musculature.
Yeah.
As her friend, not saying that that's what she wants or not, but so many young women are going, I work hard.
I train my bum off.
I train my bum off, but I'm not seeing that type of. But this is going to be intimately described by the young woman who is making less DHT from her testosterone, making more estrogens from her testosterone, making more 4-hydroxyestrogens from her estrogens from her testosterone. This is a young woman whose cellular level
and
is estrodominant and estrotoxic.
Yeah.
And she cannot, until and unless she appreciates this, and until and unless she takes steps to reduce, and of course that's the $1 million question, can we take steps to reduce this? And the overwhelming answer is yes, we can. Okay. But if she's even unaware of this, to take the steps in the first place. So now we come back to those super athletic young females for whom their doctor, when they did the research, here they were, no one ever even asked them what their monthly cycle health was. Are you having a monthly cycle? Is it irregular? How do you feel with the cycle? Are you on the pill? So now I answer your question. You see, Lisa, if you didn't know where you were innately on that cascade, remember, young women out there, all of the ladies out there, in a normal, quote unquote, in your natural monthly cycle,
without the pill,
that very without the pill, just you're 16, you're 26, you're 36, you're menstruating. How many of you realize that that very estrogen that you self-identify with isn't produced 24/7, 30 days a month?
Exactly. I mean, it is when you put on the pill.
But that's the difference, isn't it?
Difference.
So my very point that I'm trying to make is, in your natural monthly cycle, your body is only estrogenized. It is only under the influence of this hormone. And I'm going to step aside and make a couple more points on this, but I'll finish my point here. When you are naturally menstruating, there's only a window of about 5 to 7 days, give or take, in your 28 or 30 day or thereabouts, where you are in your unique monthly cycle, that your body is actively producing estrogens. Those estrogens are actively circulating in your bloodstream, and the cells of your body are actively responding to that estrogen. Compare and contrast that to being on the pill.
Yeah.
Where for 21 days of a 28-day cycle, not 5 to 7 days, 21 days, your body is under the influence of estrogen. And here's the thing, Lisa, that I have to admit, and again, let me be clear, all of Lisa's amazing listeners, this is not about anti-pill. The pill is absolutely, it is your right. It is something that you control. It is absolutely a godsend for different times of your life and for different young women. But you've got to ask, where are you in the spectrum of young women, and how will your body respond to this differently? And you at least need to understand that your body was not estrogenized for 21 days in your normal cycle.
No.
And here's the newest thing, Lisa, that I must admit, this gives me indigestion. Again, I have no say over the matter. But now the practice of actually having no bleed through.
No bleed through.
How many
Oh my
women are
God.
now being put on
Constant pill.
constant pill
Yep.
without even a bleed through
Oh,
period?
dreadful.
Constantly. So now you go from a normal physiology of every month, say 7 days of estrogenization, to 365 days of estrogenization.
Oh, disaster.
So now, Lisa, I am remiss, and we would be remiss if I don't quickly emphasize to our listeners, what is estrogen? What is this thing that you, okay, well, it's stopping me from getting pregnant. My hair is luscious. My skin might look really wonderful. So after all, shouldn't be a problem. What you have to understand, and our listeners out there, in the female body, and I can speak of the male and female body, I'm just going to focus on the female body for the time being. In the female body, Lisa, every single cell produces these receptors for estrogen. So if this is your cell, you have an estrogen receptor. Okay.
Yep.
And when that estrogen is produced or it is taken,
Yep.
as
On the pill.
a pill or as whatever, even certain estrogen analogs,
Yeah,
things
or
that mimic estrogens,
xenoestrogens
right?
and
Or
plastics.
xenoestrogens and plastics and so right. When these molecules enter your body, they bind to these receptors on your cells. Okay. Because by the way, estrogen doesn't do what it does in the body by just being produced and floating in the bloodstream. No, estrogens do what they do in the body by being produced, by then binding to these receptors. And what happens? This is the important point. What happens when estrogen binds to its receptor? What happens is the DNA expression, your genes in that cell, gene expression is radically altered.
Wow.
Literally, the genes, the instructions within your cellular operating manual changes when estrogen enters the cells.
Yep.
When there's no estrogens in the cells, changes.
Yep.
So now let's come back. The female body.
Apologies for the phone call, people, in the background.
The female body, in its normative circadian rhythm, experiences a gene expression shift, a change in gene expression for the days in which your estrogen was elevated, and then of course it comes back down in the normal cycle. What happens when you force your cells to go into a gene expression shift for 365 days a year without change?
And we're talking like hundreds of genes, hundreds or
Hundreds,
dozens
thousands
of genes that have been changed, turned on and off.
Turned on. And these genes impact the metabolic efficiency of your cells.
Well, the thyroid.
The thyroid function, which is why how many times we see a complete
thyroid problem
between hypothyroidism, hyperinsulinemia, the body's response to insulin, and estrodominance. We see these three. And when these three things come together, we euphemistically call it metabolic syndrome. Oh, you know,
it's estrogen.
There's a point behind it. There's an impact behind it. And the point here that I want to make is we often just think of the sometimes and arguably beneficial outward outcomes of being on the pill, okay? And I emphasize for the umpteenth time, please, this is not about not being on the pill.
No, this isn't about your choice. It's about what it does.
The pill can be what is right for you at certain points in your life, but it's about being educated that taking this hormone is not something as trivial as stopping your ovaries from producing an egg. That's not what that hormone is doing only. This hormone is interacting with every cell in your body, and it is changing the way your genes express in every cell of your body. Now,
Wow.
the point here is, if we were to do, I like to call it a heat map. If you took a young woman and you color code her body from white to red, according to which cells in her body have
Have
more estrogen
estrogen.
receptors,
Yeah.
what you will do is the whole body isn't going to be white, the whole body isn't going to be red. It's going to be shades of white and pink and red. And of course,
Hmm.
unsurprisingly, the region of the breast tissue will be some of
Yep.
the reddest cells, because those cells in the breast tissue are some of the most sensitive
Wow.
to estrogen. So what does this mean? It means that when estrogen is present in the bloodstream, the cells of the breast tissue are some of the most able to absorb that estrogen. But what happens when it absorbs the estrogen? Gene expression happens, gene expression changes happens, and the cells were designed to account for a circadian rhythm to their gene expression
Yeah.
change.
Not
When we
21
subject,
days
not 21 days,
or 28. Yeah.
repeatedly, or 28 days for that matter, repeatedly. Again, I stress, not for the young woman who is seeking birth control, maybe for a few months or periods in her life. We're speaking of the travesty of young women that have been on the pill since they were 14, and
Yep.
here they
Me.
are at 32.
Mm. And then
And
unable to conceive, or cancers, or weight gain, or cellulitis, or all of these implications
or
are happening.
the very metabolic machinery of that cell, your very mitochondrial efficiency of the cell is
Wow.
impacted during, and this brings me back to the brilliant comment by the brilliant female scientist that I was speaking of earlier, where a young woman should understand that in her natural, healthy 28-day rhythm, metabolic efficiency, mitochondrial efficiency changes in response to the ratios and the waves and troughs of progesterone versus testosterone versus estrogens. Think what happens when you put a blanket of estrogen over everything
Wow.
24/7, 28 days, 30 days a month, 365 days a year. Now, the point here, Lisa, is coming back to even more finessed point in your question is, well, that is what we've just explained happens in every young woman that goes on the pill. Every young woman that goes on the pill. But what happens when you didn't realize that you had the proclivity of making more of the 4-hydroxyestrogens?
Yeah. Yep.
What happens when you didn't realize that your ability to then neutralize the 4-hydroxyestrogen, that inflammatory estrogen metabolite, which by the way, you're now not realizing it, but you were making more of it. You were producing, when you introduce X amount of estrogen molecules, more of it was going down the 4-hydroxy pathway than the healthier 2-hydroxy pathway. If you were not aware of this, and you were doubly unaware of the molecular mechanisms that neutralize. So what is the gene? Let's just take a look at this.
Yep.
What is the gene that neutralizes 4-hydroxyestrogen? What is that gene? The gene that
COMT.
neutralizes is COMT. Okay,
COMT gene.
so
Yep.
COMT, catechol methyl transferase. This is the gene, the gene that makes an enzyme, the same named enzyme, COMT enzyme, and one of the jobs of this enzyme is that it recognizes the production of 4-hydroxyestrogen, which is inflammatory, which is pro-oxidative, pro-inflammatory,
quinones and
pro-estrogens, indeed. Because here's what happens: that 4-hydroxyestrogen. Think about it, Lisa, and all of the listeners. You took estrogen, which was binding to its receptor and causing all of those estrogenized changes that we spoke of. So, of course, what the body wants to do is it wants to limit the duration by which estrogen can bind to its receptor. So it's going to metabolize the estrogen.
Yeah, get rid of it.
But ironically, when you metabolize your estrogen into 4-hydroxyestrogen, ironically,
it's
somewhat
still doing it.
And say it's still doing in fact, not only is it still binding to the estrogen receptor, some studies indicate it can bind to the estrogen receptor actually with greater proclivity, with a
Wow.
greater binding efficiency than its original estrogens.
Gosh.
And it can induce that altered gene expression. 2-hydroxyestrogen does not do it near as much, which is why we consider the 2-hydroxyestrogen
The
to
best
be a
pathway.
safer, to be the best pathway. Well, the point here is COMT converts that 4-hydroxyestrogen into 4-methoxyestrogen.
Mm-hmm.
And now 4-methoxyestrogen dramatically loses its ability to bind to the estrogen receptor.
Brilliant.
So
Yeah.
4-methoxyestrogen is what we can now say it's no longer estrogenizing. Okay.
Yeah.
The other thing of the 4-hydroxy, going back now to the 4-hydroxyestrogen, if you're not removing it, if you are not converting it by methylation into the methoxyestrogen, 4-hydroxyestrogen, it decomposes into these nasty little molecules called quinones.
Horrible
And
things.
not very nice things. And quinones decompose into oxidants. So the whole stagnation, if, let's clarify the statement now. If, as a young woman, you did not know that you have the predisposition, whenever your body sees estrogens, whether they are internally made or externally introduced, whenever your body sees estrogen molecules, if you did not know that you tend to metabolize those estrogens into 4-hydroxy byproducts more than we would like, and B, you were not as efficient at neutralizing the 4-hydroxy estrogen by virtue of COMT, what you are unaware of is you are unaware of this thing called an estrodominant burden with estrotoxicity. You are unaware that in your normal cycle, for 5 to 7-ish days, your body is under the strain of an internal inflammatory production, internal oxidative stress, more than your female companions. And were you to then take that normal exposure, but
double
quadruple down
down
on
or
it
triple down.
by
Yeah.
going day in, day out on an estrogen source, think of what you're doing to the body.
And by the
just add
same,
one.
yeah, and by the same token, the bioidentical hormone replacement on the other end of the scale with the menarche, the menopause,
The menopausal young woman.
and we want, like, just to clarify, estrogens are not evil things. We want the body needs estrogens, and like it keeps us younger. I mean, this is the dilemma that I've been facing. The bioidentical hormone replacement keeps my bone density good, keeps me, being able to hold my muscle. My skin is better. I'm not aging as quickly. The endothelial cells of my vessels are better, etc., etc. However, I need to keep those in a balance so that I don't get too much estrogens going in, or I need to keep my progesterones up, and I need to make sure I know where my testosterone is.
There you have it.
Yeah, so that
because it's about the balance.
Yeah,
right. It's about finding, and so here's that final point. You know how we spoke about the cells, Lisa, having these estrogen receptors? Well, your cells have androgen receptors as well, and they have progesterone receptors as well. So think now, we can almost visualize a healthy cell, a healthy female cell, is one that is it's a traffic system, and it's one that is being trafficked into it at the proper ratios, at the proper circadian pulses and rhythms. Sometimes estrogens are getting in, altering gene expression in an estrogenized manner. Sometimes androgens are getting in, altering the gene expression in an androgenized manner. Sometimes progesterones are getting in, altering the gene expression in a progesteronized manner. And it is optimal health and optimal youthfulness and responsiveness to your cells is when we get that circadian rhythm, allowing the cell and allowing its operating manual, its genes, to go through this rhythm of when are the genes that are controlled and that are going to be expressed because of the presence of estrogen, the genes that are going to be controlled and expressed because of the presence of testosterone, because of the presence of progesterone. These waves and rhythms of gene expression, optimal health is when these waves happen in the optimal to and fro manner. Okay. And we can replace that optimability, and we can extend that optimability. And therein lies the brilliance of hormone replacement, of which it absolutely is something that our knowledge can afford. But unfortunately, when we do this without the appreciation of the individuality of these ebb and flow waves, and we push the system without appreciating what was the a priori tendency of that young woman. Was this young woman a priori androdominant? Was she a priori estrodominant? Was she estrotoxic? Was she estrodominant and estrotoxic? If you do not know these things, you're going to be guilty of, you're going to be at risk of using a one-size-fits-all approach that will be beneficial for 10%, 20%, 50% of women, but that most certainly equally can be deleterious for a group of young women unwittingly.
And this is what shocks me, is that we have done this human experiment. Like 85% of the population of women on the planet who are in their menstrual years have been on or are on the pill, including myself, who was on it for 25, 30 years, I don't even know, and ended up with fibroids, ended up with endometriosis, even though I don't have the 4-hydroxy dominance.
Thankfully, indeed.
But because I was constantly on these things. And so now with these genetic, and this is what the point, we are able to tweak and to change. For example, I'm on organic black seed oil, which upregulates my CYP1A1, 1A2 genes, which helps me create more 2-hydroxy, because I'm red lighted, if you like, for that one as well. I take DIM so that I can slow down the aromatase of testosterones. I have a very quick CYP17A1, so I need a bit more progesterone support because I'm making my testosterones very quickly. But without this knowledge, we're just like throwing mud against the wall and hoping it sticks in the right places, and doing so many people an injustice.
And think about this, Lisa. That all-important gene
methylation
that is methylating those metabolites, including the naughty 4-hydroxyestrogen. Well, Lisa and listeners out there, there's a variation, a very, very, very well-studied variation of that COMT gene. And for those of you who are dabbling with a little bit of genetics, this is the RS4680 variation. So you can actually go look at the code of the variation, and these variations have codifications. This is the RS4680 variation, and this variation is defined by 2 alleles, 2 versions of the gene. One is a G version, G as in George. The other is the A as in Apple version. Okay, now the G version of this gene produces a version of the enzyme that is faster. It is kinetically more efficient at doing its job. And what is one of its jobs? Neutralizing 4-hydroxyestrogen. So much so that if you were a GG, if both copies of your COMT were the fast versions, the Gs, and versus if you were an AA, both versions were slow. The AA COMT individuals, the people that have 2 of the slow versions of the gene, their COMT is working at 70 to 75% slower than the person that is. We're not talking trivialities. We're not talking 5% or 10%. We're saying that if you're an AA, your enzyme is doing the job. It's doing its job. It's just doing it 70% slower than if you were a GG. Now, here's the point. If you were a COMT AA and you had the fast version of CYP1B1 making more 4-hydroxyestrogen from whatever estrogens your body is seeing, and now you're not getting rid of it. And here's the final point. There are a number of nutraceutic, nutritional intake things, environmental
Mhm.
exposures that can further epigenetically slow down count. So here's one of them. The 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 several of the molecules, the phenolics in red wine, which we could talk about whether red wine is
Wow.
good for you, one glass a week, but the phenolics in red wine epigenetically slows down COMT
Oh gosh,
even further.
I
So
didn't know that.
if you were an AA COMT already dealing with a COMT enzyme
And
that
you
is
love
doing
red
its
wine.
job, and then you go drink something like red wine that another person might have had, perfectly fine having a glass a week or whatever the case might
Mm.
be, healthily, you don't even realize that you're doing something that is actually now nutraceutically, from a nutrition perspective, working against something in you that you were even further unaware of.
Wow. And
Okay?
then if you layer on that you don't have optimal B12 levels and folate levels, and your methylation process is
Method
slow,
is,
and your
well, now we're really
superoxide
putting,
within, yeah.
you're really putting fuel on the fire. So
And
for all
this
of the
leads
listeners
to,
out there,
yeah, this leads to sorts of things like cancer.
it leads to cancer. It leads to, again, I keep saying, even before we get to cancers, it leads to a quality of life that can be so radically either
Mm,
improved if we knew, or simply a quality of life where we're simply being told, well,
that's
that's just
just
some
the
of the
way it
things
is.
that that's the way it is.
Mm. Wow, Dr. Mansour, I know you've got another appointment coming up, and we have to jump off the call. And I don't really feel like we've finished this conversation. So again, I'm going to have you back, and we have to go over the male hormone report too, because everything that we've said today is also valid for the men in different ratios.
100%,
Same
100%,
cascade. And
100%.
what I want to get across, though, Dr. Mansour, is that you have the power now to be able to understand these genetics. So you and the DNA company have a hormone report, which I'm going to link to in the show notes, that people can go and order. And I like, the only reason I'm doing this is because I want people to get this report. I want them to understand their genetics, and I want them to optimize their genetics and make informed decisions around their hormone replacement, or their pill, or their what nutraceuticals to take, whether you should take DIM, whether you should take black organic seed oil, goodness knows what, all of these things that we can do to optimize our pathway. So I'm going to be linking to that in the show notes, that Dr. Mansour's company has this report now, and you can find out exactly what you should do and how to optimize your actual personal hormone situation. Dr. Mansour, is
And
there anything you wanted to add there?
well, Lisa, shortly, the short answer, no. A little longer than the short answer is to emphasize what you've just said. This is about empowerment. It is the empowerment of being informed about your unique predisposition. What is your operating manual, making your more normative uh, choices, if you will, of these cascades, and then how do you optimize the things that you want to do and the things you don't want to do. And it is this empowerment that we really want. It's not about negating any choices you have. It is rather simply about empowering you to either make healthier choices, or when you make certain choices, you make them informed about the limitations of those choices, and then you do your best to mitigate any consequences or implications thereof. And
Exactly.
I will end with one very quick note. As you've said, we've emphasized the ladies here and the women viewing this, but it is as important to the men. And I'll give you a very quick example. How many men going through that menopause period? I'm 48, I can tell you a thing or two about that, right? But how many men have come to me having felt that they were declining in their muscle mass and declining in their performance in, both in the bedroom and out of the bedroom and everything else, and they thought that testosterone was the magic fix.
Mm.
And what they did was they went and they were prescribed, in good meaning, testosterone, only to find that upon taking the testosterone, they were becoming more and more
More.
estrogenized.
Yep.
Right? Because remember, even in the men, when you take testosterone, that same CYP19A1, that same aromatase is going to convert some of that testosterone into estrogens. And men, that CYP19A1 gene comes in 3 different versions.
Mm-hmm.
A version that is going to convert your testosterone into estrogens much faster, medium speed, and slower. And so if you don't know which version of CYP19A1 you have, you do not know what is your body's natural tendency to convert testosterone into estrogens, which can have so many implications on the choices you make per going on a hormone replacement.
Yep. And that's a thing that I'm discussing with my husband and my brothers at the moment, like the implications of testosterone therapy, and it's not it's a very simplified thing. Oh, I'll just take testosterone and I'll take a heck of a lot of it because then I want more muscles. It's not. That is not.
It's
Unfortunately,
not
and there are a lot of men doing that. And it works for some and it doesn't work for others because of this very intricate knowledge that we need to have before we make these decisions. So Dr. Mansour, I think that is a brilliant place to leave it. Thank you once again so much for your knowledge, for your skill at teaching such a very complicated subject. And I hope we didn't lose you guys and girls out there listening along the way. Listen to it again if we did, but make sure you go and get your hormone report done. I think that is the key, because then you will know what to do and we can help you interpret that. And so you don't need to learn all of this. You just need to know what you need to know. Dr. Mansour, thank you once again. It's been an honor to have you again.
Always, Lisa. Thank you very much.